So HBI0101 is an academic anti-BCMA CAR T, 41BB, second generation. I think that we all know that CAR T are now standard of care, cilta-cel from second line, ide-cel from third line, and they outperformed all other therapies for relapsed refractory myeloma or previous standard of care. But there's still problem with this access to this therapy, availability of this therapy because of slot, because of vein to vein time, because of cost, and this is where academic CAR T take place, and this is where their importance. And we treated we report now of almost 196 patients with the higher dose, higher dose of 800 million CAR T cells. Our eligibility criteria were more flexible and more permissive than the registrational study of the commercial CAR T. The threshold for platelet count, for example, creatinine clearance, performance status, ejection fraction, were all more permissive. The efficacy is quite similar to other CAR T, response rate of 92%. Most of them a complete response, MRD negativity in about 3/4 of the patients. The PFS is 13 months in this cohort. But we did see a difference between patients that would have been eligible or ineligible to the key registrational commercial CAR studies, and the patients that were eligible would have been eligible to the other CAR T studies. Their outcomes is better. So I think that this cohort is in reach of more advanced patients, and of course in the future it will be nice to test this product earlier, and this is what we plan in the phase 2 study. Toxicity was quite similar to other CAR Ts. We didn't see actually any grade 4 or 5 CRS. We saw 4 cases of ICANS. All were low grade among 96 patients, so this is quite lower compared to the other CAR T. We had no treatment-related mortality. Of course, hematological toxicity, infections were quite common like the other CAR T, but overall manageable. So I think this is a proof of concept that academic CAR Ts are important in this field, and will enable more patients worldwide to get CAR T.